Okay, so good day everyone. So for today's class, we will be discussing about anticoagulation therapy naman. Okay, now as you all know class, in most clinical situations, especially if hospitalized ang patient, sometimes may mga risk ang patients natin that would merit the use of anticoagulation therapy. Let's say for example, if a patient has hypertension, diabetes, okay, or has a history of stroke, okay, or nagkaroon siya ng history of heart attacks, once admitted to the hospital class, most likely the patient will be under anticoagulation therapy. Or, say for example, class, may systemic infection ng patient natin, like say for example, pneumonia. Okay, tapos long-standing na yung pneumonia niya, malamang sa malamang class, the patient will already require the use of anticoagulation. Because as you all know, okay, when you have infection class, it increases your risk for thrombus formation. Or say for example, class, if a patient is elderly, tapos bedridden na siya. So, immobile ang patient natin class, the more, if a patient is immobile, okay, tendency kasi class, blood does not flow properly. It pools in certain areas of the body. Let's say, for example, pwedeng sa likuran, pwedeng sa paanan, okay, especially sa paa class, which could lead to venous thromboembolism. Okay, or the formation of blood clots in the lower extremities. Tapos yung blood clot, pwedeng ma-dislodge, maging emboli, and could occlude certain arteries in the body. Could be in the heart, could be in the brain, could be in the lungs, leading to pulmonary embolism. Alright, so stuff like that class. So as you all know kasi class, if you have a bacterial infection, one of the things that it can activate kasi bacteria can activate your clotting factor 7A, which is the tissue factor. Okay, whenever a bacteria kasi class exists in the body, so it starts to activate factor 7A, which leads to clot formation or clotting. Okay, and of course, as you all know class, ang problem with clots is that it can pwede siyang bumara sa isang ugat, which leads to lack of oxygen towards a certain part of the body or a certain organ or tissue, which could lead to cell death, of course. Right now, of course, kasi being immobile naman, yung nasabi ko, if you are, say for example, nakahiga ka lang palagi, some patients nakahiga because hindi siya makalakad, and so on and so forth. So, nagpupool yung blood niya class in certain parts of the bodies. Ang common na culprit dyan, or common area class na nagpupool na blood, yung blood would be the legs, lower extremities. Yun na nga, which could lead to venous thromboembolism. Right? And of course, other risk factors class would include, say for example, patients having atrial fibrillation. Okay, wherein yung heart natin hindi nagpapump, yung atrium natin nagfibrillate lang, nanginginig lang. So, hindi na napupush ng maayos yung blood. So, tendency, the blood tends to pool in the atrium, which leads to clot formation. Now, the guidelines class that we will be using for this topic will be the 2011 Clinical Practice Guidelines on Anticoagulation Dosing and Management of Anticoagulant-Associated Bleeding Complications in Adults. Okay, meron din kasi class for pediatric, meron din for geriatric. Okay, pero masyadong mahaba yung topic na yun. Okay, I will leave that to you guys to study on your own. Right? Pero hindi siya kasama sa exam natin, ha? Okay, sa atin ang class would be, let's start with adults lang muna. Okay, less complicated ang topics dito. So some things that you have to remember or have to consider, okay, when doing anticoagulant dosing. So first off class, round the weight-based dose to the nearest pre-filled syringe. Okay, syringe size. Now, most anticoagulants kasi ginagamit natin dito would of course be fondaparinux, enoxaparin, heparin. Okay, yun yung mga yun yung may mga available na pre-filled syringe. Normally class, when you dose a patient, hindi natin hina-half dose lang ang mga pre-filled syringe. Sayang kasi yun, napakamahal ng isang pre-filled syringe. So normally class, whatever you compute, okay, usually kasi ang computation class ng dosing ng anticoagulants, especially yung mga sinasub-Q, is based on the weight. So therefore class, kung halimbawa, ang nakuha mo is 45 milligrams of fondaparinux. Okay, so class, ang available natin na na pre-filled syringe is 50 milligrams. So obviously, ibibigay natin lahat ng 50 milligrams. So you have to usually round it to the nearest available pre-filled syringe. Okay? So, no dose cap for obesity except for dalteparin in cancer patients. Then, consider monitoring your anti-10A heparin levels for weight greater than 120 kilograms or for patients weighing less than 60 kilograms. Now, repeat CBC after 7 days to assess for heparin-induced thrombocytopenia. Now, as you all know, class, heparin kasi, one of the major side effects associated with it is thrombocytopenia. At usually, lumalabas yan after 7 days. Okay? Kumbaga, nagiging prominent yung reduction in your platelets when using heparin after 7 days. So, you have to request a CBC Okay, after 7 days of using heparin or any heparinoids for that matter. Okay, now the only heparinoid class that will not merit checking for INR, platelet count or CBC would be fondaparinux. Siya yung considered to be the safest anticoagulant, but it's also the most expensive. Okay, na heparinoid. So if heparin exposed in prior 6 months, CBC on day 3. Usually, if a patient was already exposed to using heparin 6 months prior, so CBC would be requested after 30 days of using heparin again. Now, low molecular weight heparins are not recommended if creatinine clearance is less than 30 ml per minute. So, another thing you have to consider, class, when dosing anticoagulants or heparinoids would be the creatinine clearance of your patient. Okay, kasi these medications, class, are exclusively eliminated or excreted via the kidneys. Okay, so kidney function plays a vital role here. So here are just some nomograms, class, on how to dose our enoxaparin. So our heparinoids. So you have to remember, class, that it's always based on weight. Okay. So pwedeng 1 milligram per kilogram every 12 hours or 1.5 milligrams per kilogram once a day. So again, this one will depend on the clinical judgment of the clinical pharmacist or the clinician involved here. So for cancer patients and those at high bleeding or thrombosis risk, we favor usually twice daily dosing. Especially for cancer patients, they are more prone to having bleeding incidents. Okay, or elderly, yan. So usually, hinay-hinay lang sa anticoagulation natin. So the heparin, tinzaparin, fondaparinux, unfractionated heparin, so just refer, class, to this nomogram when we're dosing for anticoagulants. I don't need you guys to memorize this. Kahit yung mga gumagamit ng medication na to, class, would always refer to a nomogram. Okay, so just refer to this one whenever we're dosing for anticoagulants. Alright, so currently, class, I only have the 2011 guidelines. I haven't seen any revisions yet. Okay, so if you have any revisions, class, please let me know. Okay, so that I can also update my slides. Right? So, now we know, class, these are just examples of dosing for heparinoids, for anticoagulants, yung mga tinutusok natin. Okay, now, normally, class, ginagamit ito for patients who have risk for bleeding, like diabetes, atrial fibrillation, may current systemic infection, hypertension, and so on and so forth. Now, normally, sino yung mga dapat iwasan na magkaroon ng, iwasan ang paggamit ng anticoagulants? Okay, now we have, class, the, what do you call this? We have here a mnemonic, in a sense, okay, HAS-BLED, kung saan sila yung mga taong kailangan iwasan ang paggamit ng anticoagulants. Say, for example, may point system din to, okay? It also has a point system. Now, you'll be summing up, plus, the points para malaman mo kung kailangan ba siya, kung high risk ba siya for bleeding or hindi. Okay? So, usually, class, we have the term HAS-BLED. So, first is hypertension, pero kailangan i-define natin kung ano yung hypertension niya. Ang hypertension niya dapat, class, is greater than, ang systolic blood pressure niya should be greater than 160. Okay? So, if the patient's hypertension or ang kanyang BP is 150 and below, hindi tayo magbibigay ng point. Okay? Bakit, class, kinusunod yung hypertension or yung high blood pressure? Okay? Kasi, class, if your blood pressure is already exceeding 160, may chance kasi, class, na magkaroon ka ng aneurysm. At pag nagkaroon ka ng aneurysm and you're on anticoagulants, okay, mas lalala yung bleeding mo. Alright? So, yun yung principle behind this. Alright? Pero kung 150 or less ang systolic blood pressure, kaya boom-boom lang yun. No need to add a point there. Alright? Next one, abnormal renal and or liver function. So, kung may renal problem siya, 1 point. Kung may liver problem siya, that's another point, equal to 2. So, 1 point each. Okay, so ano yung usual na titignan natin dito? If the patient is already on dialysis. Let's say, for example, class, kung ang kidney function ng patient is simply reduced creatinine clearance. Alright? Hindi mo kailangan maglagay ng point doon. Okay? Ang definition natin dito ng may kidney problem is undergoing dialysis or patient has had a transplant, kidney transplant, or the patient has liver cirrhosis, or kung bakas yung liver enzymes niya is 3 times more than the normal amount, then that would mean that the patient already has a liver dysfunction. So that's a plus. That's another point. Right? Pero again, class, kung elevated lang naman ang liver enzymes ng patient, pero hindi naman like 2 times lang the normal amount, no need to add a point. Okay? Next one, patient already had a history of stroke. That's 1 plus 1. Okay? Plus 1 then if the patient has already bleeding, had a previous bleed or predisposition to bleeding. Okay? If the patient has a labile INR, International Normalized Ratio. So if you still remember class, INR, yung ginagamit natin to assess for risk for bleeding, especially when you're using warfarin. Okay, the normal INR range should be between 2 to 3 if you're using warfarin. Now, normally class, it should be less than 60% in the therapeutic range. Okay. Next one, elderly, greater than 65 years old, or patient is using drugs or alcohol or taking alcohol in excess. So again, 1 point each. Okay, ang drugs na kinoconsider dito class are antiplatelets or NSAIDs or any drug that can cause bleeding. Now, if the score class that you get is 3 or more, okay, the patient is considered to be a high risk for bleeding. So, kung kailangan niyo gumamit ng anticoagulant, you really have to adjust the dose. Okay, dose adjustment is very much recommended. Hindi ka pwede mag-empiric dosing lang dito. Okay? So, ESC recommends ito yung para sa atrial fibrillation, recommends caution when using warfarin. Now, how do we dose? Okay, babala natin yun na to. Okay. So, warfarin dosing for venous thromboembolism or atrial fibrillation in ambulatory patients. So, meaning, paano natin i-dose si warfarin? Sorry. Up until now, class, warfarin is still one of the mainstay drugs that we have for anticoagulation. Although we have already class the factor 10A inhibitors, yung mga dabigatran, rivaroxaban, okay? Yung mga gamot na yon, all right? They are now the drug of choice for venous thromboembolism. However, they are very expensive, and the problem is walang antidote for the factor 10A inhibitors. Okay? Unlike warfarin, meron tayong antidote dyan. It's simply vitamin K. Okay? And class, it's still more widely available at mas mura pa rin ang warfarin compared sa mga bagong anticoagulants. Kaya ginagamit pa rin siya up until now. Right? So anyway, normally class, when you're dosing for you're going to use warfarin for venous thromboembolism, okay, or atrial fibrillation, the target INR should be 2 to 3. And if the patient's ambulatory, normally if you say ambulatory class, ibig sabihin naglalakad, maayos yung patient. Pag ang patient mo ay naging inpatient, okay, normally we don't just give warfarin, we give other anticoagulants as well. Right? So first thing first, you need to obtain your baseline PT, prothrombin time or INR, and investigate if abnormal. Okay? Kung mataas ang INR ng patient ko, then increased risk for bleeding. So, kailangan mababa yung dose ko. Kung mababa naman yung INR, less than 2, normally, the patient is already at risk for clot formations. So, kailangan kong taasan naman ang dose ng warfarin ko. That's why, class, it's very important that you know your baseline INR before dosing warfarin. Okay, so determine use of potential warfarin interacting medicines kasi maraming gamot ang nag-interact with warfarin. So, prior to using warfarin or recommending warfarin class, check for the patient's standing medicines. Right? Document INR, target INR, and prescribe warfarin tablet strength. Provide patient education on safety, monitoring, drug and food interactions. So for acute thrombosis, overlap with heparin or low molecular weight heparins or fondaparinux for 5 days or more until INR is therapeutic. Now, why is it class na kapag may thrombosis, nagkaroon ng history ang patient ng thrombosis, prior to using warfarin, kailangan mo siyang i-overlap with heparin? Here's the thing class I don't know kung naturo na sa inyo to sa school, pero kasi class, warfarin is procoagulant. The problem with warfarin is that it's procoagulant in the first 5 days. It's procoagulant in the first 5 days. It has something to do, class, with the ability of warfarin to inhibit protein C and S, okay, which is very important for it's an anticoagulant in the body also, which depends on vitamin K for its activation. Okay? Basta tandaan niyo lang muna that warfarin is procoagulant for the first 5 days. So, if you already had an acute thrombotic attack, meaning nagkaroon nga ng blood clot, tapos gumamit ka ng warfarin, chances are, pwedeng lumala yung blood clot na yun. Okay? Kaya normally, if a patient is going to be given warfarin, and the patient already had an incidence of an acute thrombotic attack, kailangan i-overlap yung dosing ni warfarin together with heparin. Ibig sabihin, habang binibigyan ka ng warfarin, binibigyan ka rin ng heparinoids, like enoxaparin, fondaparinux, or pwede rin naman heparin itself. Right? Pero kung wala ka namang class history of any thrombotic attacks, okay, walang indication that you had a thrombus formation, then you can just start with warfarin as is. Okay, walang overlapping. Right? So overlapping will only happen if a patient has a history of an acute thrombotic attack. Right? So recommend first INR check on day 3 and 4. So here's the nomogram class for the dosing of warfarin. So normally on the first 3 days, okay, ang starting dose natin would be 5 milligrams. Starting lang naman yan. Now after 3 days, or the 4th day, check for INR. If the INR class is between 1 and 1.3, increase the dose to 7.5. If it's 1.4 to 1.5, 5 milligrams, and so on and so forth. If the INR class after 3 days is greater than or equal to 2, okay, then you have to hold 1 day, then resume it class at 2.5 milligrams. Okay, hold for 1 day. So, huwag ka magbigay mo ng gamot for 1 day, hold, and then resume class at 2.5 milligrams. Now, that's after on the 4th day. On the 7th or 10th day, okay, 7th and 10th day, check mo ulit yung INR. If it's less than 1.5, increase the dose by 15%. If it's 1.6 to 1.9, increase by 10%. If it's within the range class, then obviously no change is needed. Alright? Now, if a patient's INR class after 7 days or after 10 days, nasa greater than 6 or 6, you might want to consider giving the patient vitamin K na because very high chances na ang kanyang risk for bleeding. I remember before class, we had one patient, ang kanyang INR was 12. I think it was 12. So twice, more than twice the namatay yung patient na yun. Okay, nagkapasa-pasa siya, nagkaroon siya ng respiratory depression, then, yun, na deaths. Alright? Ang nangyari kasi is mali yung dose na nabigay sa kanya. Anyway. Now, what about class for chronic warfarin dose adjustment? Kasi itong, meron tayo dito is usually on the first 10 days lang naman. Okay, ano yung dapat na dose ng patient? Kasi dito natin kakapain kung ano yung bagay na dose para sa patient natin. Now, if the patient is already on chronic use of warfarin, so meaning matagal, maintenance nila yung warfarin, no, more than 10 days yan ang ginagamit yung warfarin. Say, for example, 1 month, 2 months, okay? So, ito yung gagamitin nating considerations when adjusting, dose adjusting for patients who are non-bleeding. Okay, meaning walang risk for bleeding. So, this nomogram is suggested for non-bleeding patients with a target INR of 2 to 3 who are out of range and who are not at high risk for bleeding. So, if INR is greater than 3, confirm muna that there's no signs of bleeding. Signs of bleeding class would include yung pamamasa, okay, easy bruising, mga ganun. So, consider non-compliance, illness, drug interactions, or dietary change as a reason for out-of-range INR and refer to this nomogram. So, this nomogram class tells you ano ang gagawin natin based on the INR readings of the patient. Normally, class, you will require the patient INR reading once a month, at least once a month. Okay? So, yun. So, if the INR is less than 2, increase it by 10 to 15%, then repeat INR after 1 week, and so on and so forth. Okay? So, base nyo lang dito sa nomogram na to. Okay? Yeah. So, again, I will not require you guys to memorize these nomograms. These nomograms are there for a reason, para maging reference when dosing patients. Okay? Okay. Now, for the bigatran naman, dosing to prevent stroke and embolism in non-valvular atrial fibrillation. So, normally, ginagamit class ang dabigatran if a patient has atrial fib. So, when dosing dabigatran class, here's something that's very important. Okay? You always have to consider creatinine clearance. Very important yan, class. If the doctor will tell you, Mr. Pharmacist or Ma'am Pharmacist, gamit natin ang dabigatran ng patient. Una mong sasabihin dyan, Doc, anong kidney function ng patient natin? Normal ba? Kung normal, sige, gamit natin ang usual dose ng dabigatran. Pag hindi, you have to adjust it. Now, if the patient's creatinine clearance is greater than 30 ml per minute, okay, normally, ang ating dose niya will be 150 mg orally twice daily. Okay? So, yun. What about if the creatinine clearance is between 15 and 30, meaning mababa talaga yung creatinine clearance? Then we can use class 75 milligrams orally twice daily naman. Kumbaga half the original dose. Right? So there's no recommendation class for creatinine clearance that is less than 15 ml per minute or if the patient is on dialysis. Wala tayong recommended dosing dyan. Okay? Pero normally, if that happens, we just give the lower we give the drug at its lower spectrum. Okay? 75 milligrams orally twice daily. Now, what about, ano ang gagawin natin if we have to provide anticoagulant reversal? Meaning, nagtitake ang patient anticoagulant ko, may signs of bleeding na, how do I stop it? Okay, so we have the mnemonic class HAS-T. So first, hold further doses of anticoagulant. Consider antidote. So for vitamin K antagonists like warfarin, ang antidote natin would be this vitamin K. Okay, for heparinoids, we have the protamine sulfate. Okay, while for factor 10A inhibitors or yung mga NOACs natin, novel oral anticoagulants. Okay, ito yung mga factor 10A inhibitors. Okay, wala tayong antidote for them, although we have antibodies. Okay, we can produce antibodies against them. Pero of course, wala pa ata sa Philippines nun. Normally, what we do, class, to reverse the effects of NOACs would be hemodialysis. Right? So, supportive treatment, volume resuscitation, inotropes as needed. Okay? When we say volume resuscitation, class, ito yung pagbibigay ng NSS. Bibigyan natin ng swero yung patient. Or inotropes, like digoxin. Local or surgical hemostatic measures, topical agents like aminocaproic acid or tranexamic acid will be considered. Or pwedeng transfusion of blood products like red cells, platelets, as indicated. And investigate for bleeding source. So, there are 3 terms, class, na gagamitin natin. Okay, kung kailan tayo gagamit ng reversal agents. Or kailan tayo ng kailan gumamit ng reversal agents. Sino nga? So, meron tayong non-urgent, urgent, without bleeding, and meron tayong urgent with bleeding. Okay, pag sa ating non-urgent, okay, reversal is elective, meaning procedures greater than 7 days away. Okay, yun yung mga non-urgent. Okay, may urgent naman tayo, meaning may signs of bleeding, may signs of na kailangan natin magbigay ng reversal agent. Let's say, for example, INR is greater than 3. Okay, pero there are no signs of bleeding. Right? So, this would require you to give the reversal agents within hours. Okay? So, kung non-urgent yan, usually greater than 7 days away, pagbigay yung reversal agents. Pero pag urgent, class, meaning may signs of bleeding na, then, emergency reversal agents must be given. So, reversal for warfarin, usually, if it's non-urgent, stop 5 days prior to procedure. Let's say, for example, a patient is going to undergo surgery. Alam mo ba yung warfarin siya? Obviously, class, pag ikaw ay binuksan, ikaw ay nag-undergo ng surgery, and you're on warfarin, pwedeng mag-bleed out ka sa operating table. Okay, so delikado yun. So hence, class, you need to stop the use of the drug 5 days prior to the procedure. Then check INR 1 to 2 days prior. If INR is greater than 1.5, then you might consider administering 1 to 2 milligrams of vitamin K per oral. Okay, after 1 to 2 days. Prior to the procedure. Now, if it's urgent, okay, if procedure can be delayed 6 to 24 hours, halimbawa, patient is on warfarin, na-aksidente siya. Okay, na-aksidente siya, nasugatan. Kailangan, say, for example, ng surgical procedure. If you can delay the procedure in 6 to 24 hours, then you can administer 5 to 10 milligrams of vitamin K, either orally or intravenous. Pero preferably, class, it would be given intravenously. Okay? What else? Always check for the INR. Okay, if it's high. And if it is still high, class, okay, you have to give, again, vitamin K, 5 to 10 milligrams per oral or intravenously if sustained reversal is desired. Now, what about kailangan mo ng immediate, it's urgent and the patient is already bleeding. So, obviously, do HAS-T. Okay, then give vitamin K, 5 to 10 milligrams IV. Hindi na optional to. Okay, kailangan IV na. Repeat every 12 hours as needed. Okay? Now, what about for low molecular weight heparates or heparinoids? Or actually, heparin din. So if it's non-urgent, hold day of procedure, meaning if the patient is going to undergo surgery, so 1 day before the surgery, stop na. Okay, the thing kasi class with warfarin is mahaba yung kanyang half-life. Kaya usually 5 days before the procedure, kailangan tumigil na. Okay? Pero for warfarin or for heparinoids, maiksi lang naman yung half-life nito. So once daily dose lang regimen or half dose prior. Pwede rin twice daily regimens, whole evening dose a day prior to the surgery or the procedure. If it's urgent, wait 12 to 24 hours if possible. Consider protamine sulfate if delay not possible for high bleeding risk procedures. Again, if it's urgent, #T, give protamine sulfate and consider recombinant factor 7A. Okay? Or magbigay ka ng clotting factors sa patient natin. Now, protamine dose for reversal of heparin and low molecular weight heparinoid. So, ito lang siya class. If it's heparin, its half-life is 1 to 2 hours. Okay? Enoxaparin, dalteparin, tinzaparin. Then, these are the doses class of protamine sulfate that you will be using. Okay? So, I won't explain. You just read on this class. So, what about for the bigatran? Or any factor 10A inhibitors. Pero the drug of choice pa rin will always be the bigatran for the NOACs. Okay, so if it's non-urgent, hold for the doses of the bigatran, then check for creatinine clearance. Okay, kasi based on the creatinine clearance, doon tayo magbabase kung gaano katagal, kung ilang araw natin i-hold yung drug. Okay? Yan. Ito sinabi ko sa inyo class, there is no antidote available for factor 10A inhibitors or the NOACs. Normally, you just give hemodialysis. Right? Now, what about class? Okay, what about if you are to convert your anticoagulants to and from the bigatran? Halimbawa, may mga incidents or may mga scenarios class that would merit you changing a patient's medication to the bigatran or vice versa from the bigatran to warfarin, say for example. Okay, tawag natin doon is bridging. Okay, nagbi-bridge ka. Magbi-bridge ka ng gamot mo. So say for example, if the patient started with warfarin, then shift to the bigatran. Ano ang gagawin natin? So normally you have to discontinue warfarin and start the bigatran when the INR is already less than 2. Okay, now what about kung the bigatran to warfarin? Right? Ang target INR mo should be 2 to 3. Again, check for creatinine clearance. Okay? Diyan kasi tayo magbe-base. Diyan tayo magbe-base on how what's the dose of our warfarin. Kaya tayo magbibigay ng warfarin. Okay? Or, ito yung mas common. Low molecular weights heparinoids or heparin change to the bigatran. So, usually you start the bigatran after 2 hours before administration of the last heparin dose or at the same time as discontinuation of infusion of heparin. But if it's the bigatran to low molecular weight heparins, then again, assess for creatinine clearance or kidney function first. Okay, so let's have your class A sample case. JT is a 55-year-old man with a past medical history of chronic kidney disease. So let's just put that into consideration. May kidney disease siya with type 2 diabetes, okay, and hypertension. He is admitted to the hospital for community-acquired pneumonia. Okay, so meron siyang pneumonia, which obviously would merit the use of anticoagulants. And during his stay, he also diagnosed with atrial fibrillation. The resident who presents JT on rounds knows that recent changes were made to the American College of Chest Physician guidelines for stroke prevention in atrial fibrillation, but he does not recommend the specifics. He asked the clinical pharmacist whether the bigatran would be an appropriate medication for stroke prevention in this patient. Right? So normally class, when we do this, we can check for check for the CHA2DS2-VASc score. And CHA2DS class or CHA2DS2-VASc scoring would determine whether or not a patient needs to use anticoagulants. Okay, so ito yung scoring system dito. May CHA2DS and then the CHA2DS2-VASc. CHA2DS2-VASc class yung pinaka prominent na ginagamit natin ngayon. Just check. Okay, man tayo. So ano meron ng patient natin? Meron siyang hypertension. Okay, wala naman siyang CHF, right? Anong age niya? 55 years old. Okay, our patient is 55 years old, so wala tayo dito. May diabetes ang patient natin. Wala pa siyang stroke. Okay, hindi pa naman siya nagkaroon ng stroke. So, X yan. Vascular disease, si X naman. Okay? And then female, hindi naman siya female, man siya. So our CHA2DS2-VASc score is 2. Now, based on the ACCP 9, antithrombotic therapy for atrial fibrillation, if your score class is 2 or more, then you might want to use oral anticoagulant therapy. Normally, class, it's aspirin plus clopidogrel. Okay? Pwede rin naman ang treatment as aspirin plus clopidogrel. Or, pwede rin dabigatran, 150 milligrams twice daily. This is more preferred class than using dose-adjusted warfarin or VKA, vitamin K antagonist. This is vitamin K antagonist. Okay, vitamin K antagonist class would be your warfarin. Okay, so mas preferred daw si dabigatran 150 milligrams twice daily than vitamin K antagonist. So, mukhang pwede naman, right? Okay, mukhang pwede naman. Pero, may kailangan tayong tandaan, class. Ano ang problema with dabigatran? Tandaan nyo, pag gagamit tayo ng dabigatran, you always have to check for kidney function. Okay? Patient has a history of long-standing, a history of chronic kidney disease. So, before, pwede tayo magdabigatran, don't get me wrong. Okay? Pwede tayo magdabigatran, okay? Especially yung CHA2DS2-VASc score natin, okay naman eh. It would merit the use of dabigatran. Pero, class, you have to check for creatinine clearance first. Okay? So, pwede 150 milligrams twice daily. Okay? Pero dahil nga sa kanyang CKD, check mo na creatinine clearance, then adjust the dose as needed. If it's lower than 30 ml per minute, anticoagulation with warfarin with a target iron of 2 to 3 should be selected instead. Right? Kasi class, kung less than 150 ml per minute, then that would indicate that the patient's kidney function cannot handle the dabigatran. So sabi nga natin kanina, di ba, mas preferred si dabigatran, pero kung ang kidney function niya is masyadong mababa, kaya kanyang creatinine clearance is too low, then you might want to consider using warfarin na lang. Kaya sabi nga, hindi pa rin mawawala si warfarin. Okay, so let's have another case here. CP is a 61-year-old, otherwise healthy man, scheduled to undergo total hip replacement. The surgical team decides to start enoxaparin, a low molecular weight heparin, after his surgery for venous thromboembolism. Now, why would you give a patient who underwent hip therapy, hip replacement, meaning orthopedic surgery to, okay, why would you give a patient like that anticoagulants? Okay, the reason for that, class, is if it's an orthopedic patient, obviously, may giging immobile yan for quite some time. Okay, di ba? Anong sabi natin, class, pag immobile ang patient, pag hindi siya gumagalaw, di ba, tumataas ang risk for bleeding. Okay, kasi napupool yung blood in certain areas of the body. And the most common problem, class, if a patient underwent total hip replacement therapy is venous thromboembolism, meaning clot formation in the lower extremities. Usually sa legs, nagkakaroon ng clot formation doon. Di ba, ang mahirap kasi dyan is pag yung clot na yun naging emboli at bumara sa puso, sa baga, or sa utak. So during rounds on the surgical floor, the clinical pharmacist reviewed the patient's medical chart and decides to visit the patient to address any questions. Patient mentions that he is ready for surgery but is concerned about having to be on blood thinners for a long time after his surgery. So some things that you might want to take note of. The 9th edition of the CHEST guidelines recommends low molecular weight as the preferred agent in patients undergoing major orthopedic surgery, such as hip replacement therapy. Alternative medications would include fondaparinux, heparin, warfarin, or aspirin. Apixaban, dabigatran, and rivaroxaban are also alternatives suggested in patients undergoing total hip or knee replacement. Okay, pero after surgery, class, normally mag-enoxaparin ka talaga. Okay, then currently, class, the guidance suggests VTE prophylaxis be continued up to 35 days. So meaning, yes, the patient will be on anticoagulants, pero only for a month or so. Okay, only for 35 days. Now, after major orthopedic surgery, and as it further reduces the incidence of post-surgical venous thromboembolism without an appreciable increase in major bleeding risks. So yes, sasabihin natin patient, mag-undergo po kayo ng anticoagulation therapy, pero only for 35 days. After 35 days, reassess, check for risk for clotting, PTT, INR. Okay, PT, INR. Okay, pag sinabing high pa rin ang risk niya for clot, then we might extend the duration of the anticoagulation. Pero kung hindi naman, then we can always stop it after 35 days. So the pharmacist should inform primary physician that he will start his anticoagulation with enoxaparin 12 hours after his surgery and continue it for a total of 35 days. Normally, class, mag-bridging tayo dito, ha. Alangan naman na araw-araw for 35 days, mag-enoxaparin ng patient. Okay, mag-bridging tayo. So, pwedeng heparinoids to dabigatran or heparinoids to warfarin. So, mag-bridging tayo dito. Since CP's risk for a clot is highest during this time period, it's important, the importance of good medication adherence should be reinforced. Okay? Or pwede rin naman class, enoxaparin to dabigatran pala. Okay? Alright. So that's pretty much it, class, for anticoagulation therapy. So thank you very much for listening, class. And I hope you learned something regarding anticoagulation therapy. So thank you very much.